Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know for pathology. What's happening in this image? You know what organ this is without reading the description? You see those pyramids, right? Yes, the kidney, but not just any typical kidney. This one is actually showing acute renal failure. We're going to be discussing this and much more in this presentation on acute renal failure pathology. This is discussed in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Acute renal failure. What is that exactly? Well, acute renal failure is the acute, severe decrease in renal function that develops within days, right? Now you see this kidney here again, bivalved, one section of this kidney showing marked pallor of the cortex, contrasting to the dark areas of the surviving medullary tissue. The hallmark of acute renal failure is azotemia. Excessive amounts of blood urea nitrogen and creatinine in the blood, often with oliguria. The etiology of acute renal failure is divided into three important things that you must know: the prerenal azotemia, postrenal azotemia, and intrarenal azotemia. With acute renal failure, you need to know that there's a pathophysiology associated with it, right? Over the span of minutes to hours to days to weeks that the condition unfolds, per se. Here we have renal ultrasonography of a patient with renal failure after surgery with increased cortical echogenicity. So prerenal azotemia, let's talk about that for a bit. Prerenal azotemia is caused by renal failure and decreased blood supply to the kidneys. Prerenal azotemia frequently leads to acute renal failure and is considered as the common cause. Reduced blood flow causes oliguria, azotemia, and increase in glomerular filtration rate. Reabsorption of fluid and blood urine nitrogen ensures that the serum BUN to creatinine ratio is greater than 15 and that tubular function remains intact. Is less than 1% for the FeNa, right? And urine osmolality is greater than 500 milliosms per kilogram. On the other hand, you could have postrenal azotemia. Postrenal azotemia occurs when there is a restriction in the urine's flow. Postrenal azotemia is typically seen in cases of neurogenic bladder, prostatic hypertrophy, right, causing a blockage, bladder neck blockage, per se due to cancer, posterior urethral valves, retroperitoneal fibrosis, or bilateral ureteral obstruction from tumors or stones. Decreased outflow results in decreased GFR, azotemia, and oliguria. During the early stage of obstruction, there is increased tubular pressure, The increased tubular pressure forces blood urea nitrogen into the blood, with serum BUN to creatinine ratio having greater than 15, and its tubular function remains intact. So a FeNa less than 1%, and urine osm greater than 500 milliosms per kilogram. Those are important numbers to know, especially the BUN to creatinine ratio greater than 15 and the FeNa less than 1%. With long-standing obstruction, the tubular damage can ensue, resulting in decreased reabsorption of blood urea nitrogen, decreased reabsorption of sodium, so the FeNa starts to increase, and inability to concentrate the urine. So the urine osm actually starts to decrease below 500 milliosms per kilogram. Now let's talk about another common entity, right? You have to know about this because it shows up a lot. Acute tubular necrosis. What's that? Well, acute tubular necrosis is defined as the injury and necrosis of tubular epithelial cells. Acute tubular necrosis is the most common cause of acute renal failure, or so-called intrarenal azotemia. With ATN, necrotic cells plug and obstruct renal tubules. Obstruction of the renal tubules decreases the GFR. The most common feature of acute tubular necrosis is having a small amount of urine output, right? Small, which appears to be brown with granular casts. The tubular epithelium is dysfunctional, which reduces blood urea nitrogen reabsorption. Serum BUN to creatinine ratio is less than 15. There's decreased reabsorption of sodium, so the FeNa is greater than 2%, and inability to concentrate urine. So the urine osm is less than 500 milliosms per kilogram with acute tubular necrosis. The etiology of acute tubular necrosis may be classified as either ischemic or nephrotoxic, lacking oxygen, or due to chemical compounds, right? Ischemic or nephrotoxic. With ischemic acute tubular necrosis, this happens when the tubular cells do not receive enough oxygen. Ischemic tubular necrosis is often preceded by prerenal azotemia and excessively high levels of nitrogen waste products in the blood. The thick ascending limbs proximal tubule and medullary segment are especially vulnerable to this ischemia damage. Now, on the other hand, with nephrotoxic acute tubular necrosis, this occurs when toxic substances are exposed to the tubular cells, right? Makes sense? That's why it's nephrotoxic. The proximal tubules are extremely susceptible to acute tubular necrosis. Causes of nephrotoxic acute tubular necrosis includes aminoglycosides, right? The most common cause of nephrotoxic acute tubular necrosis is aminoglycosides. Remember that. Also remember heavy metals such as lead, myoglobinuria, for example, due to a crush injury to the muscles, ethylene glycol, which is associated with Oxalate crystals, right, will be present in the urine. Radiocontrast dye can cause ATN of the nephrotoxic type, as well as tumor lysis syndrome, and that's due to the urate. So these are some common causes of ATN of the nephrotoxic type. They tend to show up on clinical vignettes, FYI. So make sure you understand this. Right? You got it. Now, prior to starting chemotherapy, right, hydration and allopurinol are used to reduce the risk of tumor lysis syndrome induced acute tubular necrosis. Clinical features of acute tubular necrosis include oliguria, brown granular casts, high levels of blood urea nitrogen and creatinine, and metabolic acidosis with hyperkalemia. Although acute tubular necrosis illness is treatable because it is considered reversible, supportive dialysis is often needed because electrolyte abnormalities can be lethal. The symptoms of acute tubular necrosis, specifically oliguria, might last for 2 to 3 weeks before the patient's recovery. Acute tubular necrosis takes time for the tubular cells, which are stable cells, to re-enter the cell cycle and regenerate. Remember, we talked about that with the stabile cells, the labile cells. We talked about that, remember? Remember the stem cells, right? Remember the cells at the basal layer of the crypts in the GI tract, right? And the skin cells that allow rapid regeneration of skin tissue, right? Now, acute interstitial nephritis. What is that exactly? Well, acute interstitial nephritis, aka intrarenal azotemia, is caused by drug-induced hypersensitivity involving the interstitium and tubules, or I should say can be caused by. For example, to the right here, we have an H&E image. Can you recognize where this is from? Right? You see that glomeruli, right? In the kidney. This is showing acute interstitial nephritis, the inflammatory infiltrate involving the kidney. The etiology of acute interstitial nephritis includes NSAIDs, penicillin, and diuretics. Symptoms of acute interstitial nephritis include oliguria, fever, and rash. You might see those. And the rash is associated with acute interstitial nephritis, typically will appear days to weeks after starting a drug. And eosinophils may be found in the urine in patients with acute interstitial nephritis. For example, let's take a look at this kidney biopsy here from a patient with drug-induced acute interstitial nephritis. Can you see the eosinophils that are present there? There's at least 20 of them, right? You remember what an eosinophil looks like with its bilobed nuclei and it's very eosinophilic, hence eosinophil coloration, right? The pink, hot pink. Exactly. Symptoms of acute interstitial nephritis may actually resolve with drug cessation. Isn't that fantastic? Renal papillary necrosis, however, may develop and progress in acute interstitial nephritis. Speaking of renal papillary necrosis, that is a kidney disorder in which all or some of the renal papillae die. Renal papillary necrosis is characterized by gross hematuria, right? Can you imagine urinating and seeing blood? That's what it is. As well as flank pain. Risk factors for renal papillary necrosis include diabetes mellitus, especially when it's uncontrolled, right? That's why we need to take care of our patients, make sure that they understand that they need their hemoglobin levels, or their blood sugar levels, hemoglobin A1C specifically, to be normal. Sickle cell trait and disease are both associated with renal papillary necrosis. Severe acute pyelonephritis and chronic analgesic abuse as well. And with that, you've completed another presentation, well on your way to success. You're going to dominate and win, and I'm here to make sure you do that, providing you with everything that you need to succeed in pathology. Keep doing your thing, and I'll see you next time. Till then, take care.